It's our pleasure today to have with us Dr. Yasidian from the Tata Institute of Social Sciences in Mumbai, India. Dr. Yasidian arrived in Houston last night, came on to College Station this morning, is leaving this afternoon, and he is on very much of a whirlwind. So we appreciate him spending some time with us today, sharing with us some of his own work on the economic impact of diabetes on households in India, looking for policy options. He has a very fascinating background. Just in a nutshell, I'll share with you, his doctoral degree is from the Tata Institute. His master's degree is in health research and also in social work. He has been the director of the research program for the Tata Institute and is now the dean of the School of Health Systems Studies. So he's been with the Tata Institute in one way or another since about 1980, somewhere around 1980. He has also worked with the World Health Organization in a variety of different capacities and has a tremendous interest in bringing public health interventions to populations and seeing if those can influence and impact policy and create policy changes. So we're delighted to have him with us. We have an hour max, and then we have to move on to another item on the agenda. And then at 2 o'clock, he'll be meeting with several of our students who, in fact, will be going to Mumbai, going to India in December for an intensive 3-week period of time, both doing coursework and also spending time in one of the research laboratory communities, looking at some of the public health issues being faced in urban populations in India. So join me in welcoming Dr. Yasidian to School of Rural Public Health, and thank you for sharing your expertise with us.
Thank you. Thank you for the introduction. Thank you very much. It's very nice to be here, and we look forward to have more interactions between your school and my school in the coming years. And your dean was with us, I think, in the month of August, and we had a lot of discussion. And today also we would be looking at the possibility of working together in the coming years. So, and we found the School of Public Health here and the School of Health System Studies in Mumbai have lots in common to learn from each other, share experiences. So as a small step, we in the month of December, January, that I think 7 students from here will be coming there for a 3-week program on urban health, where they will be having a very short classroom session followed by field labs placements in the urban poor communities, guided by my faculty, my colleagues. Then they will be taking certain very specific projects to do and get understanding of urban health problems in a developing country, more specific to India. So, and this is just a beginning. Then I hope there will be more exchanges and common work together. So that's what we plan to do. Anyway, today I thought I will share with you some information about my little work I have done on diabetes in India. Non-communicable disease on the whole in India is a neglected area. Because there is a reason for that, because the country is still in the grip of communicable diseases and maternal and child health. And we are still struggling to achieve the Millennium Development Goals. So, there is a lot of focus on that, but at the same time the country is in a state of transition. So, that is transforming the epidemiological profile is transforming in the last 2 decades. So, it is a very serious problem which is emerging in the country as far as non-communicable diseases are concerned. So, there are 3 kinds of transition that is taking place in the last 2 decades. One is a demographic transition. It is a young country. There is a continuous increase of child population in all these decades, but for the first time in the history of the country, in the last year's census, the trend has reversed. The child population has started showing declining trend, whereas the adult and the older 60 plus population showing a upward trend. So, this is a very important transition, demographic transition that has been set in from this decade. The second one is the urbanization. The country is predominantly rural. 30% of the population in the country live in villages, but certain states like Tamil Nadu, Kerala, Maharashtra and Gujarat, these are large states and which are in the forefront of economic development, and where we see the urbanization trends are much faster, and these states have urban population of 45% plus. Like Tamil Nadu, it is almost 50%, some 49% urban as per the 2011 census. So, some of the states have moved much faster towards the urbanization. Then the economic transition, as you know that the globalization and economic reforms that started taking place from 1991 in the country. So, in these 2 decades the agriculture sector has, there is a declining trend in the agriculture sector, and the manufacturing sector used to be very labor intensive, but it has now become capital intensive and technology driven. So, the workforce has been considerably reduced in the manufacturing sector, but more significant thing is the emergence of service sector, especially the IT, information technology sector, and the finance sector has emerged as a major service sector. And this service sector serves not only the country, but as you know the globally with because the IT sector can function from anywhere. So, there is a economic transition. So, these 3 transition has tremendous impact on the epidemiological profile of the country. So, in these 2 decades the disease profile also has started changing, and for the first time in the history of the country, the cause of death, the predominant cause of death is non-communicable disease. That is, in 2011, according the statistics shows 52% of the deaths that had happened are due to NCD. So, it is the first time from communicable disease to the cause of death is non-communicable disease. At the same time, the morbidity of non-communicable diseases are tremendously on the increase, but at the same time the maternal child health issues and communicable disease issues are still very much in major challenge for the public health field. So, it is a kind of a dual burden of disease that is faced with government, but government still all the programs are focused for MCH and communicable diseases. So far the non-communicable disease is not in the radar of the public health intervention or planning of the government, but it is a major emerging problem in the country. Among them, the diabetes is one disease which is very high prevalence. I will just come to that point. But at the same time, there is very little research or done or information available on a disease NCD like diabetes. We do not have a national level sample survey done on diabetes, but I would like to say that diabetes research is going on in the country since 1970. But all these studies are mainly to find out what is the prevalence, but different studies having different methodologies, standards. For example, some studies say adult is 30 years, some studies try to see the prevalence. Somebody define adult as a 22 years. So, there is no comparability of many studies that are going on, but most of these studies are just trying to estimate the prevalence, nothing beyond that. Then we do not have, as I said, there is no studies on economic impact or social impact or health seeking behavior. So, we do not have any such studies. So, but I have just looked at, reviewed all the research that has been conducted in the country. So, these are some of the observations from all these studies I have made, but I would like to point out these are studies which are conducted in certain parts of the country. Some are slightly bigger studies, but many studies are very small studies. So, you have to keep that in mind when you look at these observations. See, from the different studies, the estimation of how many patients are there, it varies from 40 to 60 million. So, you can imagine the difference of different studies. So, that itself shows the problems in methodology, standards and measurement. And the southern states, the southern part of the state, which have tremendous economic development since the last 2 decades, they have higher prevalence. And within that states, cities have extremely high prevalence of diabetes. And the dangerous trend that is happening is the pre-diabetes to diabetes is very large number. So, the future, it is, we can say that in future the number is going to increase tremendously, where this pre-diabetes stage they are going to move to the diabetes stage. And another thing is the time or gestation period between the pre-diabetes stage and diabetes stage is shrinking. So, the number is going to increase much faster rate. So, that is especially in a state like Tamil Nadu. Then the onset of the disease, the age at onset of the disease is continuously decreasing. So, today you see diabetes in the age of 30 or 28 or 40. So, it is no more a disease that sets in after 50. So, the age is also, onset of the disease is also continuously coming down. Now, there are small studies to show that the number of cases diagnosed to number of cases not diagnosed, or what you call unknown cases, is many. So, it shows that there is lack of information, especially in rural areas and among the urban slums or among the poor, urban poor. It is almost, certain studies shows it is 1:1. If you have one case of diabetes which is diagnosed, there is an undiagnosed case is another one, or certain studies in Goa which shows it is 1:3. One case of diabetes, but 3 cases are not known, but it is there. So, this shows the magnitude of the disease that is hidden in the country. So, what is the bottom line? That is bottom line that India has the largest number of diabetic cases in the world. So, we have say 15% of the global disease burden of diabetes is in India. Among all the diabetes patients, 15% of the patients or in India. Like the prevalence rate may be the highest in USA, but the number in terms of the percentage to the total number of diabetic cases is very large in the country. It is the number one in the world. But we do not have any national data. So, in that, so what I have done here is, I would like to in this slide explain to you what I have done to gain understanding of the economic aspect. There is a national sample survey conducted every year, which basically study the national expenditure pattern. Now, they do not study health information at all most of the time, but one particular round, which is the 60th round conducted in 2004, we can see it is a very old data, but that is the latest data for the country, which has somehow studied the medical expenditure when they were studying the economic expenditure. So, that is only one data set which has studied the morbidity of the country and how much people are spending money on healthcare. From that, I have taken out those households where diabetes is a problem, and I have analyzed those households and to see to look at the economic impact. So, what I have done is I have taken the national, analyzed the national data, and 3 southern states, that is Kerala, Tamil Nadu and Andhra Pradesh, where the prevalence rate is almost double the national prevalence rate. So, this is the these are the 3 states, Kerala, Tamil Nadu and Andhra Pradesh, where the prevalence of diabetes is quite high. But these are the 3 states where the economic development in these last 2 decades, that is the post economic reform period, is very tremendous. So, these are the 3 states I am analyzing, as well as for the whole country. So, if you look at here the all India figure, the prevalence rate, I would like to say this data is the self reported. So, it has its limitation, it is not diagnosed, but self reported cases of diabetes. So, we should keep that in mind. So, this is the national prevalence rate is 3.5, but the urban is much higher than the rural. But if you take Tamil Nadu, which is 7.7, which is more than double, and here also Kerala almost double the national average. So, all these, and as expected, the urban thing, especially in Tamil Nadu, it is almost 14% in the urban areas. And this is the economic status. We have taken that the lowest 40%, middle 40%, and the 20% the affluent. And as expected, the affluent have much higher prevalence. So, that is okay. Now, where do they go for their treatment? So, there are, one is outpatient treatment and the inpatient treatment. You can see predominantly it is the private sector, this one, and the government facilities are least used, almost less than 20%, except in Andhra Pradesh little more. But when hospitalization comes for complications due to diabetes, there is increase in the use of the government facility, almost 1/3, even at the national level, 1/3 is government facilities. But Andhra Pradesh is because this has a lot of implication in the subsequent slide. So, you see only 15% people have gone to the government hospitals, whereas 84% are still using private facilities for hospitalization, which is quite expensive. So, how much they have spent. Outpatient, it's in Indian rupees, but you can see the exchange rate which was in 2004. Now actually exchange rate may be more than 50. So here you can see it is outpatient, it's not a big amount, but when it comes to inpatient, you can see the Andhra Pradesh has almost or more than doubled the national level and more than double compared to Kerala and Tamil Nadu. So what you see in Andhra Pradesh in the last slide, the public facilities are very limited. So very few people are using the public facility for hospitalization. It has repercussion here that people spend. It is because it's not like US, everybody has insurance. So so it is out of pocket expenditure. So you spend from your pocket. So that is quite high in the case of Andhra Pradesh because the public facilities, hospital facilities are very limited in that particular state. So this is in relation to their economic status. You can see the Andhra Pradesh, the affluent spends substantially high, but you see the poor spending more than 6,000 Indian rupees, whereas in the state like Kerala, in the rich people, even the rich spend only 5,000 because the public facilities are much superior in the state of Kerala. So people tend to use that where you get the highly subsidized health service. Similarly, Tamil Nadu also, but Kerala is a very good example. But at the national level, you find it is still higher than these particular two states. Yeah. So the proportion out of pocket expenditure to their total household expenditure. So that's the thing. You see the Andhra Pradesh, even the poor people spend more than 1/3 of their household expenditure goes into treating these diabetes. So a family member sick in the going for hospitalization and other treatment, outpatient, then the family more than 1/3 of the expenditure goes on that, whereas you find Kerala it's much smaller. But even in the national level, it is much higher. You find here 20% of household expenditure goes on treating diabetes. So where do they get this money? So you find their savings. So it's outpatient, which is a small amount, so it is out of pocket from their savings. But when it comes to hospitalization, you see this line, which is the borrowing. So in Andhra Pradesh, 2/3 of them have to borrow money to meet the hospitalization. And at national level also, it is quite high, actually, almost 30%, 28%. And Tamil Nadu also, it's high, half of them. But Kerala, it is the least, where the public facilities are. So there is a large out-of-pocket expenditure, but how they meet is the borrowing. So this is a major economic impact on the households, like especially a state like Andhra Pradesh. The health system that is existing, where we have a federal system, maybe like yours, where the different states have different healthcare delivery system. So a state like Kerala, which has a very good hospitals, public hospitals, where a lot of facilities are free. Tamil Nadu, which has very special program for diabetes, but Andhra Pradesh doesn't have that kind of a facility where you will see that how much people have spend and have to borrow to meet the expenditure. So this is a major. So there's a lot of studies in the country talking about how hospitalization leads to poverty. So this is the very typical example that diabetes is one such disease that can generate more poverty in the country. as compared to any other like communicable disease in the country. Yes. That's a good question, because they don't go to banks, they go to money lenders and they fleece them. So that's why I'm saying the poverty, pushing them into poverty, is due to disease. Yes, diabetes is very high. So they have to these are the people, many of them may not have even bank accounts. So these are the local money lenders who make a lot of money out of this. So it ultimately lead to selling their land to pay that, or he will take over your land. So that kind of situation. So having said that, I would move on to the policy initiative. That, as I said, there is not any non-communicable disease as such in the policy radar of the government. But in the 12th plan, which is we have 5-year plans in the social sector. So in the 12th plan, which is starting now, there is a consideration by the government. The government has set up a subcommittee to on NCD, and that subcommittee has recommended these 3 diseases have to be taken as a priority: cardiovascular disease, cancer and diabetes as priority diseases, to have government invest on that in the 12th plan period. So we hope that the subcommittee just makes a recommendation, but the decision is with the planning commission. So it is hoped that at least some investment will be done in this 5-year plan. But at the same time, governments, the state governments have independently taken initiatives, like Kerala and Tamil Nadu have such initiatives, but Tamil Nadu especially, they have a World Bank funded project on diabetes. So they are training doctors at the primary health center level, so that people could get diagnosis done at the village level, then get the outpatient treatment at the village level, then they can move to district level if they need more there are complications arise, then they can go to the district hospitals. So the future policy initiative of the government is, it is on paper, that is on promotion, prevention and disease management. So these are the basic principle of having the new policy. One is on health promotion at the community level, school level and workplace. Then the prevention is dealing with the risk factors. Obesity, like in US people talk a lot about obesity, but in India we have started discussing this, because one side you will find a lot of poor people, but other side obesity is getting a more serious problem, because we have now a expanding middle class population, and you find school children who are obese in middle class families. So obesity is a problem, and also the youngsters who are working in IT and finance, it's a very typical sectors where you find young 20 in their late 20s, they are obese. So these are really major problems. Then dealing with the managing the disease, that we do not have any standard protocol. Like as I said, 80% are going to the private sector. Now private sector in the country is so diverse, and it can be a highly qualified physician at the one end of the spectrum. Then you will find a generalist, then you will find people who are supposed to practice Ayurveda or homeopathy, which are indigenous medicine, but they practice modern medicine. They treat diabetes patient with modern medicine. And then the other end of the spectrum is people who do not have any qualification. The fellow might have worked as an attendant in under a doctor for a few years, and he must have seen his doctor is giving certain medicine, so he will be started treating them in, especially these are the people you find them in poor areas, in slums, in villages, they are doing it. So this is a major issue in the country. So, they are regulating the private sector. At the same time, the government, if they government is in a big dilemma, because if they regulate it and eliminate all these people, then there is no doctors for maybe the 2/3 of the country, because all these highly qualified doctors are all in cities, and they are not, we do not have the numbers to move into the, they are either in city or they are in US or Europe. So, they are not in other places. So, we do not have people to work in small towns or in cities. So, it is necessary to government to come out with that, then see to it these are complied. Then also the complications dealing with retinopathy, renopathy, like the eye problems and renal diseases, cardiovascular disease and diabetes foot. These are government is planning to develop at the district and the teaching hospital level. So, this is the policy proposal of the government, that is health promotion, prevention and disease management in the 12th plan, but we hope that this will be seriously implemented. But at the same time, as I said, there are projects which are already doing this, like in Tamil Nadu under the health system project funded by the bank, which is doing this extremely well. So, based on that, we are the government, the national level, the federal government is planning to come out with these policy guidelines. So, but all these policy guidelines may not really translated into plans or programs unless you have good research evidence. So, this is a major area where the country is today lacking. So, unless you have good research and good evidence produced, the policies you are talking about, when you are trying to implement it on the at the ground level, you will find they are meaningless. So, so there is a need to find out at least basic thing, how many diabetic patients in the country. So, even that is not there. So, unless that is there, government cannot plan how much money to allocate and what to do. So, the estimate projections are vague, and so that is one area. Then there is a need for some in-depth study to really come out with and find out the unknown cases, and there are smaller studies. There are like there is a Christian Medical College which is running diabetic clinics in remote areas. They see the number of cases have increased almost 10 times after the clinics have started. They have registered in the clinic. So, you can see that. So, there is a need to even detect case detection is very important. Then there are studies surely to, I have presented very rudimentary data on economic impact, but we need very serious studies on, very scientific studies on economic impact as well as the social aspect of the disease, which is not done so far. Then finally the health seeking behavior, that understanding is very necessary, because you want to see the pathway of utilization. Who is the first contact? Normally we have anecdotal evidence to say they will go to chemists in the shop to get certain tablets and take, or they will go to this fellow who has no degree at all and practicing in the neighborhood. So, we need scientific evidence where these people are going and when they are shifting from one provider to another provider. So, this kind of information is not at all present. So, unless this is put in place and this information is available, then that the slide which I showed, the previous slide, has meaning. Then only you can translate that policy into action or intervention will be possible when you have. So, what I am trying to say, a country like US where there is a lot of research done on diabetes, there is a lot of scope like for a school of public health like this to work with this, our school there back to study these kind of studies and come out with answers. So, that is my last slide, I think. Thank you.
I have a question, sir. doctoral student in the Department of Health Policy and Management. In the U.S., rural and underserved populations bear a disproportionate share of diabetes burden. But from the slides, the initial slides you showed, the urban population seems to have, a very large proportion of diabetes in India. So this is my question. Is that a contextual thing, or would this be due to reporting such that the rural people who live in rural areas, only a few of them report diabetes and we have more reporting in the urban areas?
Yeah, rural. There are 2 points there. One is the rural area, people are involved in agriculture and other occupations which involve a lot of physical activities. The second explanation is, as I have said, the data is not there. So the prevalence, so that is the major concern, that there is unknown cases in villages which is never registered. So this is the concern, that unless you find out those, what is the real, where you find 1.5 in village, the rural areas, and 3.5 in urban areas, which may be a misleading figure also. So that's so unless you clarify these things, so people may say, okay, they are doing agriculture work, so they are physically active, so they don't suffer from diabetes. So that is, you have to prove that, otherwise you cannot take that for granted. My understanding is there is a lot of unknown cases in villages.